Anemia in pregnancy, that is the most common mortality in females of India. Anemia, so it may be physiological or pathological. Coming to physiological, hemoglobin is greater than 11. Principle is hemodilution, and here is less than 11. Pathological, and principle behind the pathological conditions are it is mainly due to decreased hemoglobin, pathological conditions such as jaundice, etc. And peripheral smear is mainly always normochromic, normocytic, microcytic, macrocytic, or hyperchromic. Causes are physiological anemia is due to hemodilution. Most common cause of anemia in pregnancy. Acquired is nutritional deficiencies anemia. Most common pathologic is iron deficiency. It is due to hemolytic anemia or anemia of chronic disease or aplastic anemia. Inherited are thalassemia, sickle cell anemia, and hemoglobinopathy is inherited hemolytic anemia. So decrease in hemoglobin concentration will be maximum around second trimester. Pathological anemia is common in low socioeconomic status conditions. So definition of anemia according to WHO is less than 11, and according to CDC, it is first trimester hemoglobin less than 11. So mild hemoglobin is 10 to 10.9, moderate 7 to 9.9, severe is less than 7. So very severe is only by ICMR, given less than 4. Effects of anemia on mother is directly affected by the pathology, and placenta-megaly is due to pure oxygenation of fetus. So there are antenatal, intranatal, and postnatal. Antenatal is maternal stress, where there is release of maternal glucocorticoids, increases placental CRH, premature activation of HPA axis, and DHEA is increased, and placenta makes estrogen more, and there is preterm labor or pre-rupture membranes. So in intranatal, there is uterine inertia, there is pure contraction due to less oxygen, and postpartum hemorrhage, it is due to poor contractions. And there is pregnancy-induced hypertensions are more common or more incident in antenatal causes, and there is increased chance of venous thromboembolisms in postnatal causes, and folic acid deficiency and antepartum hemorrhage or abruptio placenta are seen in antenatal causes, and increased chance of postpartum depression is seen in postnatal causes. There is poor wound healing, and congestive heart failure is most common. Effect of anemia on fetus is indirectly affected by the pathology, that is fetal stress, and there is low birth weight. Coming to laboratory diagnosis of anemia, so it is done by HB screening is done by digital hemoglobinometer. As per international guidelines, check for hemoglobin twice, at first antenatal visit and during 28 weeks, that is at the start of third trimester. As per Indian guidelines, check hemoglobin for 4 times in an antenatal woman for minimum 4 antenatal visits. If at all it is less than 11, upon screening, evaluate further CBC, take a peripheral smear, and take HB electrophoresis, that is for suspecting sickle cell anemia or thalassemia. So in thalassemia, the MCV is normal. RBC count is also RBC count is reduced and less than 13 in thalassemia, greater than 13 IDA, and range of MCV in pregnancy is around 75 to 100 femtoliters, which is around normal in thalassemia, and 80 to 85 in the average is the average MCV in majority of pregnant women. So differential diagnosis using peripheral smear are, we see microcytic and macrocytic anemia. So microcytic is mainly due to iron deficiency, thalassemia, sideroblastic anemia. So here the mnemonic is SITA, sideroblastic anemia, iron deficiency anemia, thalassemia, and aplastic anemia. Macrocytic anemia, the mnemonic is Lady Hardinge Medical College. So we go for liver diseases or hypothyroidism and megaloblastic anemia and use of cytotoxic drugs. Megaloblastic anemia. Most sensitive RBC index for IDC is MCHC. Earliest and best, and it is the most sensitive parameter to detect IDA is serum ferritin levels and also TIBC levels too. Serum ferritin level normal is 20 to 200 micrograms per liter, and serum iron in iron deficiency anemia is less than 40. TIBC is around 325 to 400 micrograms per DL. Serum iron or TIBC transference saturation normal is 25 to 15%. So there is decreased pallor, hypochromic anemia, microcytic, and serum hepcidin. It helps to differentiate IDA from anemia of chronic diseases. So it is decreased in IDA, serum hepcidin. Gold standard method to diagnose IDA is bone marrow biopsy. Bone marrow biopsy is the absence of stainable iron, not used as it is invasive. It is the last investigation to be done. So anemia in pregnancy, so the treatment is mainly by 3 different methods: oral iron therapy, or parenteral iron therapy, or blood transfusion. Oral iron therapy is mainly 2 iron folic acid tablets per day. So HB increases 3 weeks later at a rate of 0.7 grams per deciliter per week. So here is a scenario: 22 weeks pregnant female had HB8. She was given 2 IFA tablets per day. Her HB count 3 weeks later was 8.7 gram percentage and 9.4 gram percentage on 4th week. Hence, HB levels can be checked every month. And alternative options in non-compliant patients are: change the salt of iron in affordable patients from ferrous sulfate in IFA to ferrous fumarate. Unaffordable patients, go for parenteral therapy. In parenteral iron therapy, indications are in non-compliant patient, non-tolerant patient, and indications based on gestational age. So calculating parenteral iron dosage in micrograms using Ganzoni's formula is where 2.4 into weight in kg, pre-pregnancy weight in kg, and hemoglobin deficit, that is if 11 is the patient's hemoglobin, it is called hemoglobin deficit, plus 500 milligrams for storage. Scenario: an example is calculate dose of parenteral iron in a non-compliant female with pre-pregnancy weight 45, recent HB 10. So 2.4 into pre-pregnancy weight 45 into 1, that is 11 minus 10, 11 minus patient hemoglobin 10, and plus 500, 608 milligrams. Parenteral iron approved by Government of India is iron dextran, first generation, iron sucrose, second generation, ferric carboxymaltose, third generation. Management of severe anemia: mild to moderate in gestational age. If at all she is in 34 weeks of gestation, give oral iron tabs 2 per day. Check HB after 3 weeks or 1 month. If more than 34 weeks, parenteral iron, non-compliant intolerance. Severe anemia, HB at 5 at any gestational age, go for blood transfusion. HB 5 to 6.9, gestational age, if it is more than or equal to 34 weeks, go for blood transfusion. Less than 34 weeks, go for parenteral iron therapy.